Professor Dr. Subhash Prasad Acharya, Vice President of SAN, as a moderator for today's debate, pro-con debate on which is better, CVP or PICC.
We'd like to thank the scientific committee for SAN 2026 to give this opportunity to talk about, to go through this, to arrange this pro-con debate on PICC line and CVP. So, in this pro-con debate, we'll be talking about CVC and PICC lines. So, to start with this session, without delay, I would like to first call upon our speaker, Dr. Pankaj Joshi, to talk about introduction to the basics of CVC and PICC lines.
Good afternoon, everyone. So today I'll be talking about introduction to the basics of central line and the PICC line. Main theme is the debate. So before starting the debate, just I'll be doing some basics. We all know at the end of the session, I think we'll be able to know what is central line and what is PICC line, understand the basic indications and purposes, identify key anatomical differences, and also compare and contrast the various advantages, disadvantages, and the uses. So we all know central line because we have been using it in our day-to-day practice. It is a very thin, flexible tube that is inserted into the large veins, usually internal jugular vein or subclavian vein, or sometimes femoral vein, with the tip resting at the central vein near the heart, usually cavo-atrial junction. Usually it is indicated for therapeutic indications, monitoring indications, and the access indications. The therapeutic indications like for the long-term chemotherapy, for use of multiple vasopressors, for giving the hypertonic solutions, and for prolonged antibiotic therapy, or sometimes in case of total parenteral nutrition, and also when we give the concentrated electrolytes like potassium, Also, it is used when you are giving multiple concurrent therapies and also in the long-term therapy. So this is usually the therapeutic indications. Usually the lines are kept in the veins at the neck. Sometimes it is also used for the monitoring indications like for central venous pressure monitoring, central venous oxygen saturation monitoring, or for the frequent blood sampling. Also, when the access is very much difficult, or in the case of emergency vascular access situation like in the court situation or the massive trauma that need rapid vascular access, or if there is very poor peripheral access like in case of obesity, IV drug use, chronic illness, or in specific clinical scenarios like oncology, transplant, and ICU patient who require long-term and frequent vascular access. So, we all know the contraindications, usually uncooperative patients, coagulopathy, infection at the site of insertion, or thrombosis at the planned insertion vein, or distorted anatomy that can make central line insertion very much difficult. These are the contraindications. So this was about the basic of central line. Now I'll be going to talk about PICC line. So both of the central line and the PICC line, the tip usually sits at the cavo-atrial junction, but the slight difference is that this is a little bit long, thin, flexible tube that we usually insert through peripheral veins. There are usually three peripheral veins that we use. Those are basilic vein, brachial vein, and the cephalic vein. And most commonly, the basilic vein is the preferred site of insertion. And its tip usually terminates at the lower third of the superior vena cava, as you can see in the picture. So its indication, as if with central line, is similar to the central line, like prolonged IV antimicrobial therapy or chemotherapy in the oncological therapy. And most of the time, we have been using PICC line in the centers that deal with onco patients. And also it is used to give total parenteral nutrition or in patients with poor peripheral venous access where repeated peripheral cannulation is impossible, and also for frequent and prolonged IV treatments also in the venous access in the community, like if you want to discharge the patient to their home, it is more safer than the central line. So contraindications are similar to the central line. That is, one is the no suitable peripheral vein. Even in ultrasound, if you can't find a suitable peripheral vein, that is one of the contraindication. Or contraindication to the catheterization of SBC is also the contraindication to the PICC line insertion, active infection at the site, known or suspected bacteremia, also the patient refusal. And the relative contraindication is in the chronic kidney disease, because we usually do not put PICC line in the patients with chronic kidney disease, as it has been shown that there is increased risk of central venous stenosis, thrombosis, which may compromise future arteriovenous fistula creation. So usually in the chronic kidney disease, we do not put PICC line. Also, it can severe coagulopathy or thrombocytopenia can be a relative contraindication, but we can improve the coagulopathy by transfusing the products before putting PICC line. Also, lymphedema or post-mastectomy status on the plant site may be a relative contraindications, and also persistent uncontrolled agitation, also history of frequent catheter-related thrombosis are the relative contraindications. So coming to the comparison, usually the site where you put PICC line is on the basilic, cephalic, or the brachial vein, while traditionally the central venous catheters are put at the central veins near the neck, like interjugular vein, subclavian vein, or the femoral vein. So risk of immediate complication is little bit less with PICC line than the central line. Risk of catheter-related bloodstream infection is generally lower with PICC line than the short tunnel or non-tunnel CVC. Risk of thrombosis, usually it is higher with PICC line than with the central line. And more comfort for patient comfort and use, I think PICC line is more comfortable. And for duration of use, usually PICC line is placed in patients who require long-term, medium to long-term therapy, mainly weeks to months. But for central line, it is for short-term therapy, usually for days to weeks only. And main applications of the both are usually PICC line is for sustained long-term therapy, like long-term antibiotics, chemotherapy, or TPN. But central line is usually for acute and critical care, rapid infusion, resuscitation, monitoring, and sometimes dialysis. Okay, this was the basic. Thank you.
Thank you, Dr. Bongas. I'd like you to sit on the dais, please, because we'll have question and answer session toward the end. So as we now know about the basics of CVC and PICC line, the main objective of this pro-con debate was to start the discussion about the use of PICC lines. Peripheral inserted central lines has been one of the armamentarium in the skill of an anesthesiologist, but we found that it has been dying out and nobody is using PICC line nowadays, and intervention radiology is taking over that skill. So we feel that this skill must be rejuvenated and brought back into our armamentarium, and we should start putting more PICC. But before we go on to that, let's see what the experts have to hear about central line or PICC line, which is better. So now I'd like to call upon Dr. Abhiya Pradhan. She is an onco-anesthetist at KMC, Kathmandu Medical College Teaching Hospital, and she thinks that central venous catheter is better. Let's hear from her.
Hello everyone, respected seniors, my dear colleagues and my juniors. Thank you for the scientific committee for letting me talk in this debate today. Today we will be talking about the battle between the tubes, the heavyweight champion that I think is central venous catheter or CVC versus the convenient challenger, peripherally inserted catheter, widely known as PICC line. Okay. So on the broader picture, today we'll be talking about speed versus convenience, critical power versus the long-term comfort. When seconds matter, when shock progresses, which line do we trust? So today I'll be talking that the central line is the main gold standard thing for survival. So I'll be talking brief about history. Central line was discovered in desperation, and also in desperation, and by German doctor Forsman, who proved that heart catheterization was possible, and by doing it on himself. And moving on to the early 1950s, Seldinger's technique was developed, and it was a safer outcome for central lines. And then it was massively used for shock management, massive transfusions, and dialysis. Then after that, in 1970s, tunnel catheters, which are commonly used as chemo ports, and also for Hickman lines were developed. They were also used for total parenteral nutrition. Then peak lines were introduced. So the key thing is CVC evolved for survival and peak lines evolved for long-term convenience. Now looking on the spectrum of venous axis, the peak line is also a central venous axis, but the route is different. So there are central lines which are non-tunneled, which which was earlier told about, it was standard CVC, and the tunnel ones, which is not told about mostly, is the externally visible ones. That is tunneled is the Hickman's line, and totally implanted one, which is commonly known as chemopods. So visually, the central lines are seen to be sent from the internal jugular vein to the near to the heart. It is wider and broader. And the other picture shows the chemopods, which is totally implanted and it is not visible. But peak lines are different. They go from the arm, they take a narrower route through the either basilic vein or cephalic vein or brachial vein. And then they take a longer route and go to the vessels near the heart. So it was evolved for a concept of long-term antibiotics for outpatient chemo patients who can go to their home, taking home chemotherapy, as well as to avoid complications of needles being stuck in the chest or in the neck. So this is the main difference between CVC and peak line. But in emergency, flow equals to survival. In cases like in septic shock, polytrauma, massive transfusion, in cardiac arrest, peak line, it does not match central venous catheter. It provides a wide bore access, and the vasopressor infusions can be given along with massive transfusion protocols can be carried out in it. Even the physics denies central peak lines because it has a longer length with high resistance and shorter and lesser wider lumen. So the central lines, they provide more flow to the peak lines, as when the width increases, there is more flow, that is 4 times more flow according to Poiseuille's law. Central line does not only deliver, but it also monitors. It monitors the central venous pressure, the SCVO2, and it also is taken as an ideal thing for accurate hemodynamic monitoring. So these are the technical specifications. This has already been discussed that these are narrower, but the dwell time is most important. Peak lines are said to be kept for around 6 months. But the tunneled central lines, that are the Hickman and the port ones, they can be kept surprisingly for about, it's been written in literature that it can be kept for about 19 to 38 years as well, if it is managed properly. And regarding the complications, there are insertion complications in peak line. Initially, peak line was said to be discovered to lower the risk of pneumothorax, which was caused by the central lines, but ultrasound has drastically reduced the complication nowadays. Another complication is thrombosis. Thrombosed PICC lines are associated with a high degree of upper limb DVT in some populations, particularly oncology patients who are already hypercoagulable. Oncology patients are different ball games because they already have biological risk of hypercoagulability, and when we put a long line which is causing injury to the small vessel, they create more risk of thrombosis. And it is usually kept for chemotherapy, and when it is stopped due to hypercoagulability and other conditions like occlusions, then the chemotherapy is stopped. Then that is an absolute disaster. So there has been a study in the Journal of Vascular Surgery where a systematic review of randomized controlled trials have been done, and it has been said that there is significant occlusions in the PICC line, and there is significant systemic infections and local infection rate is high with the PICC lines, and thrombosis, that is catheter-related thrombosis, is high in them, which is followed by phlebitis and accidental removal of these PICC lines. Relating to the thrombosis, the same study, it shows that there is about 10 to 25% of DVT in the PICC lines, and in the central line, the chemoport especially, there is very less chances of DVT, that is 2 to 5%. So PICC line increases the risk of DVT 2 to 3 times compared to the central lines. And catheter-related bloodstream infection in PICC line is seen as 1.1 to 2.1 per 1,000 days of catheter. And on ports, that is the central tunnel ports, these are seen as 0.1 to 0.7 per 1,000 days of catheter. There have been multiple meta-analyses shown that significantly lowers the rate of infection in ports. There are other complications as well, which is commonly seen with PICC lines, that are malposition, phlebitis, which is up to 50 to 20% in oncology series, and there is extravasation of the vesicant drugs, accidental removals, which is very less in the ports. So another journal, British Journal of Radiology, which was published in 2023, it is said that the overall complication that is seen with central lines, either ports, tunneled CVC, or standard CVC, there is a lesser risk of complication compared to the PICC line, which is 4 times higher than the other central lines. Now, talking about the cost, effectiveness, and value, we might be thinking that PICC lines are of lesser cost compared to chemoports. But the thing is, in oncology patients, the chemotherapeutic management is sometimes extended up to 12 to 24 months as well. So for the initial time period, that is up to 6 months, it seems to be cheaper. But PICC lines turn expensive over time because of the maintenance, the dressing supplies, reinsertions, thrombosis management, and infection management. And they've also studied about the quality of life. The central lines, basically the chemoports, has been unanimously found to be associated with superior quality of life because of less activity limitations and fewer daily restrictions. So on today's clinical scenario, CVC are gold standard in ICU, trauma, emergency medicine. PICC lines are preferred for prolonged IV antibiotic use, chemotherapy, home therapy, but in modern practice, we have to think about the right line in right patient. And in high acuity medicine, CVC dominates. And to conclude, PICC line evolved for comfort, CVC evolved for survival. When speed matters, flow matters, monitoring matters, and life support matters, CVC remains superior in critical care medicine. So I conclude saying CVC is better than PICC. Thank you.
Thank you, Dr. Avia. Please be seated. Now, we'd like to hear a different opinion. I would like to call upon Dr. Subi Regmi. She is an onco-anesthetist from Chiton Medical College Cancer Center. She will be talking about, or she thinks that PICC is better than central line. Let's hear from her.
Thank you, sir. Very good afternoon, everyone. I am Dr. Subi Regmi, And in today's pro-con debate, I am team pro-PIC, and I believe that PIC is better. So, central venous access, it has become a cornerstone of modern medical practice. We use central venous access for hemodynamic monitoring, administration of vasoactive drugs, long-term IV therapy, chemotherapy, total parenteral nutrition, and so on. But all lines are not created equal. Some lines demand more restrictions, more monitoring, and more risks. So this is a study that was published in 2024 in JAMA Internal Medicine. So it included 130 studies that evaluated placement of 2,14,325 central lines. So we often tend to normalize placement of central line like it's nothing nowadays, but it carries risks, it is an invasive procedure, and this study showed that it is associated with most common mechanical insertion complications like arterial puncture. The rate is still high, that is 68.8 per thousand placements, where internal jugular vein ranks the most, followed by pneumothorax, where it is rated as 9.9 per thousand placements, where subclavian vein ranks the most, followed by arterial cannulation with the rate of 2.8 per thousand centrally inserted central line placement. So, as my opponent said, we can say that ultrasound guidance did decrease the risk. Arterial puncture dropped from 68.8 to 13.5 per thousand placements, and pneumothorax dropped from 9.9 to 2.4 per thousand placements. Ultrasound helped, we can see that, but it did not eliminate the risk. Now, talking about insertion safety, PIC lines, the name itself, it's peripherally inserted central catheter. There is no central puncture, no carotid or subclavian artery puncture, no pneumothorax, no hemothorax, no vagal nerve stimulation. That is, there is near zero mechanical complication risk during insertion when we're talking about PIC, as there are no critical structures around. Next, I'd like to highlight the patient experience, which becomes an anatomical reality in case of centrally inserted central line and peripherally inserted central line. In central lines, the puncture area is around neck and chest, and it is associated with high level of anxiety and discomfort among the patients. Patients require head rotation, Trendelenburg position, immobility, and some may even require sedations. Whereas if you look at PIC placement, it's a simple upper arm access, and it's psychologically less threatening for the patient. It is comparable to mere peripheral IV cannulation in patient's perception. There is minimal repositioning, no airway proximity. So we can say that PIC has transformed the central access from hospital-bound to patient-centered care. Patients can eat, talk, mobilize, sleep without a catheter dangling from their neck. The dressing care is easier, and it's validated for outpatient chemotherapy, home antibiotics, as well as ambulatory TPN. So I'm not saying all of these things on a mere whim. There are evidences. So according to this article that was published in Journal of Vascular Access, where central vascular catheters were compared to the PICs in Greek health system, they found that PIC line insertion offered significantly more procedural comfort and relative line satisfaction among the patients. They also reported that conventional central venous catheter insertion has a steeper learning curve compared to PIC placements, owing to deeper target veins, proximity to critical structures, and higher risk of mechanical complications. So let's just forget about central lines and PIC here. When safety, efficacy, patient satisfaction was compared between a simple IV access and routine PIC placement, procedure-related distress was comparable between the PIC and the IV access group. And in fact, patient satisfaction was higher in the PIC group compared to the usual IV access group. So talking about an important clinical and economic implication of placement of central lines, CLABSIs, that is central line associated bloodstream infections. Talking about our own burden here, A prospective ICU surveillance study in Nepal reported a CLABSI rate of 8.64 per 1,000 central line days, highlighting the local burden of central line associated infections. These bloodstream infections, they drive morbidity, mortality, longer hospital stays, and overall higher treatment costs. So we don't have any local studies that have compared central lines and PICS, but I'd like to highlight a few specific population here. So first, let's talk about this meta-analysis that was published in 2024, where the incidence of catheter-related bloodstream infections in different central venous access devices was analyzed. And they found that PICC lines ranked the highest for lowest infection risk, with a 97% probability of being the best performing central venous access device, while the conventional central venous catheters that we put in our patients day in and day out in our ICUs ranked the lowest. Maybe this was because of the upper arm line insertion that avoids high bacterial density areas like neck, chest, and groin. Next population that I've taken here are the hematological cancer patients, as PICC and central lines and central venous access devices are most commonly placed in these patients, and they are at higher risk of development of CLABSIs as well as thrombosis. So this meta-analysis included 8 studies with 2421 patients, where 1186 received a PICC line and 1235 received a central venous catheterization. Their pooled analysis showed that risk of CLABSI was significantly lower with PICC lines as compared to central line. And even regarding thrombosis, they found that there was no any statistically significant increase in thrombosis risk with PICC, but heterogeneity limits their definitive conclusions. So next population-specific study that I've kept here is conducted in the ICU setup, where PICCs are now gaining popularity. So this retrospective analysis analyzed the compared the microbial colonization between the central venous catheters and peripherally inserted central catheters. So they found that catheter colonization cases were higher in the central venous catheters, with more multi-drug resistant organism isolated in these catheters when compared to PICCs. So let's talk about cost effectiveness. I'd like to differ with my opponent here. So direct device cost is never the true cost of care. So we've seen that CLABSI, central line is more there, CLABSI is more in central line, a mechanical complication during insertions. Central line again ranks the highest when compared to PICC. So there is more requirement investigations and interventions here, therefore more money is used. Again, if we talk about the duration of catheter use, CVCs are designed in such a way that they're only, that we can only use them for a short term, whereas PICCs, they can be utilized for weeks to months, and even 6 months or more if they are maintained correctly. Again, the rate of replacement and reinsertion is higher in central line group than compared to the PICC group because of the higher complication or infection risks that requires line removal and reinsertion. So the MAGIC guideline, that is the Michigan Appropriateness Guide for Intravenous Catheters, also advocates that we use central lines only if we are anticipating a short-term therapy. That is, if only your patient is going to be in the ICU or in the onco center for a short term, that is between 5 to 7 days. For medium to long term, you go with PICC or tunnel devices if you have them. But non-tunnel CVCs that we generally put in our ICU patients, they are not recommended for medium to long-term duration unless clearly indicated. So PICC, it has gained an access in our intensive care unit nowadays, and the recommendations are that these lines should be preferred in patients who have major anatomic abnormalities of chest and neck, patients who require tracheostomy, patients who have coagulation abnormalities, obese patients. PICC tends to be very useful in obese patients, and patients who are likely to be at a higher risk of catheter-related bloodstream infections. So to conclude, I'd like to say that central venous access, I think the rate of mechanical complications is higher, patient comfort is higher in PICC, learning curve is higher in central lines, infections is higher in central lines, duration of use is higher in PIC, need for reinsertion is higher in central lines, and outpatient suitability is good for PIC and poor for central line. So now it's time that we know that central access is more than a procedure, and it's time for us to choose our lines wisely. Thank you.
Thank you, Dr. Subi. So before going on to the rebuttal with both the onco-anesthetists, I would like to call upon our judge for today. I'd like to call upon Professor Ritu Pradhan. She is the head of Department of Anesthesia and Critical Care at B. Hospital, NAMS. Please have a seat. Thank you. So now we'll be going on to the rebuttal. I'd like to call upon Dr. Abia for her rebuttal.
So I'm kind of pre-prepared for my rebuttal. As my opponent said, peaks are safer because they avoid pneumothorax. As already mentioned, ultrasound-guided CVCs, they significantly reduce pneumothorax or arterial injuries. And there have been a lot of comparative studies that shown that complication rates are comparable when ultrasound is used. So in high acuity center, the risk of delayed resuscitation outweighs small difference in insertion trauma. And PICS has lower risk of infection. That is a thing we have to think about because infection risk, it depends on the setting and the protocol. In ICU patients, multiple lumens and heavy infusions, the CVC bundles, if they've done properly, then with sterile protocols, the infection risk, it equalizes. And PICS can have catheter-related bloodstream infection lesser, but especially in immunocompromised patients, we have to rethink about this thing that putting a PIC line can have lower risk of infection. And PIC is better for long-term use, that has been said by my opponent, but in oncology patients, PICs may be better for long-term therapies, but as I've already said, when the chemotherapy goes more than 6 months, then there are problems with PIC lines. In oncology patients, these PIC lines, they have got higher risk of thrombosis, and tunneled catheters, they can be used, in many studies they have said that it can be used for the chemopods especially, they can be used for 19 years to 38 years. Yes, it sounds very difficult to take in, but there have been studies where it have been kept for these long years when it is managed properly. And PIC lines, they can be used for dialysis as well, as large bore needs cannot be made by the PIC lines. And PIC has a lower thrombosis risk. I think that it does not make any sense because in cancer patients, the hypercoagulable state is already there, which is a biological risk for these patients. And when putting on a PIC line, it is a mechanical risk, and there is higher catheter-related thrombosis in these kind of lines, and there have been a lot of meta-analysis from 2023 to 2025, depending on these kind of cases. And PIC is sufficient for most cases. We have to rethink about it because PIC works stable for a long-term therapy, but it cannot replace in conditions like septic shock, massive transfusion, hemodynamic monitoring, dialysis, and even stem cell transplant are done with the tunnel central venous catheters. So take-home message is we should not be thinking about suitability, but we have to think about superiority. And as I've already said, the PIC lines, they are even discarded by physics, the laws of physics. So in high acuity global practice, CVC, it remains more versatile for life supporting platform. Thank you.
Thank you. Now we'll hear from Dr. Subi about her rebuttal on what Dr. Abhi has just said.
Thank you, sir. So unlike Dr. Abia, I don't have my rebuttal pre-prepared. So there are a few things that I'd like to highlight that she recently mentioned. First is regarding thrombosis risk. So I believe the studies say that thrombosis risk is not device dependent alone. It depends upon patient selection, it depends upon the technique of the cannulation, and it also depends upon the catheter-vein ratio problem. Modern evidences, if you look at them, it shows that when catheter to vein ratio is less than 45%, which is measured under ultrasound guidance, and when proper tip conformation is done while inserting a PICC line using a C-arm or an X-ray, thrombosis risk in fact drops significantly. And if we're really talking about thrombosis here, we've all read about internal jugular and subclavian CVCs or ports. They also cause thrombosis. And we also know that subclavian stenosis is well documented in literatures. So I'd like to tell my worthy opponent that if thrombosis is the argument here, it applies to all the central lines. I'm sorry, it's not just PICC. And next thing you mentioned regarding resuscitation and hemodynamic monitoring. So we have newer kinds of PICCs available nowadays with us. Something called Power PICC. So it allows the use of vasoactive drugs, as well as we can also use it for measurement of central venous pressure. And it also has a flow rate of 180 to 300 ml per minute. So they are designed in such a way that hemodynamic monitoring is also possible, infusion of vasoactive drug is also possible, and if we're really talking about fluid resuscitation or massive blood transfusions, I think we simply have our simple large bore cannulas to defeat your physics in that. I don't think we need any central access for massive transfusions or fluid resuscitation. So, and the third thing that I'd like to highlight is regarding the cost. So I've already mentioned device cost is never the total cost of care. So complication management, infections, treatment, prolonged hospitalization, it dramatically shifts the economic burden. So you've argued that ports are better than PICC. But if you look at the cost of ports, I think it's basically the same, even Hickman's catheter. So I think even regarding the cost effectiveness, I have a better say with my PICC here. Thank you.
Thanks to both the pioneers in onco anesthesia for being here and debating. I hope you will remain the best of friends. Before we go to the conclusion, I'll see if there is any. We'll take a few questions from the audience if there is any, and then we'll move towards the concluding session. So, if there is any questions from the floor to any of the speakers, Dr. Pankaj, Dr. Abi, and Dr. Subi, about PICC lines, CBC lines. Dr. Promise, yes. Can you provide the mic, please? Yes.
Direct my question to Dr. Subi. As we have got multiple ports in the CBC, and usually the PICC line has single port, when we are using vasopressors, there is a flushing of drug, and there is some arrhythmogenic potential. What do you have to say about it? Because the drug is in the port, the space, and when you give the flush, there is some arrhythmogenic potential. So does that bother you when you are debating CBC versus PICC? Thank you.
I'm talking regarding ICUs. So we have newer PICCs, newer developed PICCs known as power PICCs. So these PICCs, they have multiple lumens as well. They are designed for a high flow rate, that is 180 to 300 ml per minute. And they are designed in such a way that you can conduct your hemodynamic monitoring as well as use your vasoactive drugs, also have a flushing channel extra. So power PICCs, they are gaining an access into our ICU. And I think for long-term use or medium-term use, I think it's time we switch our practice and go back to PICCs, because these PICCs are newly designed and they are better for critically ill patients. Thank you.
Dr. Sadiksha.
My question is for both the debaters, Dr. Abia and Dr. Subi. Actually, I just have a query. Is this the same for the pediatric patient also? Because we don't use PICC that often, but then we've been using CVP very often, very frequently. Of course, as said, with the help of the ultrasound and the complication rates are very less. We hardly see any complications. And also probably, maybe because of the care in the ICU also, we see the infection rate is also very low. So what do you have to say about this in case of the pediatric patient?
Thank you, ma'am, for the question. In pediatric patients, we had been exposed to mostly the tunnel catheter in oncological cases I'm speaking about. But in our setup in Kathmandu Medical College, for critically ill patients, we do put the PEEK lines. Though I'm going against my debate, but in pediatric patients, we are commonly using PEEK lines for critically ill patients, but only those who are not requiring more than 6 months of treatment. For those oncological cases who have been kept for about a long-term chemotherapy, we had been exposed to Hickman lines and even chemoports that is commonly done in the Kathmandu, this cancer center, Bhaktapur Cancer Hospital. We usually keep the chemoports only because it is easier for the children to have the day-to-day activities, and the infection risk is also very less. And that is meant for the oncological cases. But on the other hand, for critically ill patients who are like in a reversible state, who can be resuscitated, they are kept on the PEEK lines.
Dr. Krishna Murari would like to say something.
Thank you. My question is for Dr. Pankaj Joshi. My question might be slightly out of the specific topic being debated here, but what I have observed in my institution, Manipal Teaching Hospital, earlier a lot of, not a lot of PEEKs we used to insert there. Occasional consultation used to request used to be there, and we used to put PEEK line. But now the oncologists refer those cases to us. Now they prefer chemoport. Okay. My question is, what is the difference between PEEK and chemoport insertion? Because now in my institution the trend is towards chemoport insertion, and in a few years, in I think 2-3 years, we have hardly put any PEEK line.
I think Dr. Abhiya added that in the presentation.
Yes. So thank you, sir, for the question. This is a very interesting question because I have been talking about this the whole time. These are chemoports are kept as tunneled central venous catheter, and these are totally inside the body. Nothing is seen. So only a small port, it is seen in the subclavicular, only there is a port in the subclavicular space where you just put a needle and then you do the, either you give chemotherapy or take out blood for investigations, and even you can use the vasopressors from it. And it is getting popular nowadays because, as I've already mentioned, the rate of infection in these kind of chemoports are very less. It is like if a PEEK line says there is 10 to 25% of thrombosis chance, chemoport says there's only 2 to 5% of chance of thrombosis. And this is done, this has been said in the study which has been done as a meta-analysis from 2023 to 2025. And it is also easier for the patients, oncological patients, they are already in a lot of stress. And hanging a tube like a PEEK line or a Hickman's line itself, it is a stress for them. When nothing is seen and they can do their showers or go to swimming with a chemoport without any stress, that is why these lines are getting popular. And even the risk of thrombosis, infection, everything, overall complication has come down to very less numbers.
Okay, thank you.
Thank you. So now moving aside from cancer patients we talked about a lot, I would like to hear from Dr. Pankaj. Dr. Pankaj is a transplant anesthetist, so do you have any other difference in opinion about PEEK line versus central line in transplant patients or post-transplant patients? Do you have any opinion to add on?
Thank you. Mostly I deal with liver transplant and the kidney transplant. And in those cases, for the intra-op period, I think I'll prefer central line more because In such cases, I have to give multiple vasopressors, I have to give multiple transfusions and things. So in such cases, and as those patients won't be requiring the lines for longer durations, so central line is more preferred. But while discharging from ICU, if the patient needs any long-term therapy through the, then I think PICC line will be more suitable in such patients because of the less risk of infections and then the, for the patient comfort purpose also.
Thank you. So I think now, because of short of time, we'll be going toward the end of the program. I'll request Professor Dr. Ritu Pradhan to do the conclusion.
Thank you, Professor Subhas. Before concluding remarks, I'd like to declare that I have no any conflict of interest on these two modalities of our lines, and being I am not a judge to be here, but I would like to be in this pro-can debate. I would like to be a catalyst so that we can explore the arena of our anesthesiology, which we have left. Most of us in this hall has left that skill, and I like to regenerate the importance of PICC line, and also because I like to start by sharing my experience. When I was doing my residency, we don't have double lumen, triple lumen central venous lines. We have the Cavafix, a trade name, it's Bebron Cavafix, which was a single lumen, something like a long line. It's a PICC line actually. Now it has revolutionized, and we are talking this debate on PICC line, which is more used in onco patients right now. Now we feel like it's not a myth that the PICC line, we shouldn't keep the PICC line. It's not a myth. Like we should keep the PICC line, but we have to think about the different spectrum of the patients. So I like to conclude in 4 points, right? Indications, complications, post-procedure care, and the challenges. So indication, if we think about the set, at we have a set, no, go big 2 circles, we have the indications will be common, both in the both settings. In the set, they will be in the middle. But the only easy point with the PICC line is sometimes you are in such an ethical dilemma that you have to give some chemotherapeutic agent, and the platelet count is so low that 10,000 or 12,000 only, and the treatment has to be started because they have certain protocol. Then in that part, IV access is not every time easy in those cases. So if we start with the PICC line and we are expert in that, we can give a beautiful service to those chemo struggling patients. So in that only the indication. Other one, in other part, when we struggle about speed and resuscitation and survival, that's why we have no doubt that central venous line is good. But at the time of discharge, in the ICU patient, as Dr. Pankaj has said, then that we have to convert it to the PICC line and discharge the patient for the convenience of the patient, like that. So in complications, yes, both have complications, but regarding the life-threatening complications, the PICC has less life-threatening complications than the chemo port and other central venous lines, because PICC is a peripheral line. By saying that, we should be always keep in mind that infection rate is high in PICC line. That's why there should be proper training, and the technique should be learned, and awareness program to the one who is keeping the PICC line, to the one who is taking care of the PICC line, and to the patient, because lots of combined effort is required to make the PICC line useful for 6 weeks, 7 weeks, because for that the one who is injecting the drug in the PICC line, in the chemotherapy, like wards, nursing staffs, they should be taking care. Patient will go home, they will be happy, but they should be aware that they have PICC line, and they should take care of that PICC line with bathing and like that. In other aspects, with central line, we cannot ask the patient to go home, we have to take it out. So in this complication, that's and risk of thrombosis, yes, incidence is high in the risk of thrombosis in PICC line, but CVP is also not safe. It's a transient. In both cases, the way we take care of those line matters a lot. That's why. And in my next procedure, as both of the speakers had talked about, but I would like to highlight that one thing which is missing in this debate. In procedure, in central line, we use the Seldinger technique, but PIC line is a bit different. It's a modified Seldinger technique that we should be taking care, know that, because it's a different thing. Because PIC line is peripherally inserted central line. It is easy as an IV cannulation, as I'm one of our experts who put it in BID hospital said, and I have been involved keeping the PIC line in BID also. But when you have difficulty in keeping the PIC line, the difficulty is more than keeping the IV cannulations. So it is very challenging also at the same time. Right? And now coming to my post-procedure care, which are and challenges in both the abscess, we are getting used to with the central line. That's we feel easy and like we have ultrasound, and we are not used to with the PIC line. So it's been reluctant among us. If we go on practicing PIC line, picking up the patients who is right for the PIC line. Like, for example, in ICU, patient has thrombocytopenia, coagulopathy, but anyhow, you have to start the IV access and infusions of vasopressors and TPN, then we can go for power pick, and the job is excellent in that time. So the thing, there should be conscience to whom we have to keep the central line and to whom we have to keep the PowerPoint. That's why. And at the last, I'd like to say that we are not here, actually debate is to explore and to generate a fire about that, but actually we are not here to replace the PIC with the central line or replace the central line with the PIC. We have to remember that. But we are here to explore the arena which we have forget. So we have to again explore many things about those things and pick up the point, and we have to make a guidelines, our own guidelines at national level. I'd like to ask the both involved in the debate, because they are onco-anesthesiologists, both we have to make our national guidelines, because our population is different in different terms, in our ethnicity, in our prevalence of the cancer, and in the cost affected. And there should be also government policy for that to address these things. So for this, we have to choose the patient accordingly. Thank you, and I would like to conclude. Thank you all the speakers, and thank you Professor Subhas for giving me this opportunity. I think he is also have a great concluding remarks.
Thank you, Dr. Ritu. We are almost at the end of the session. Thank you all the ProCon debate panelists. And we'd like to mention that we had a pre-conference workshop on Pick the PIC line. So SAN has started a workshop on PIC, and Dr. Madindra Basnet is the program director for the workshop, and we'll be continuing this workshop in the future also for anesthesiologists, as well as we'll be training the nurses on PIC line. So please kindly involve your junior colleagues and residents in this PIC line workshop, so that they have some exposure about it and they feel confident about putting a PIC line. And most of the time we tell that PIC is expensive, PIC is expensive, that's why we don't put it. It's not because it's expensive we don't put it, it's because we are not confident. We think, I myself think that I'm not competent, I'm not confident to put the PIC line, that's why I'm not putting a PIC line, you know. So we do other intervention in the ICU which costs, like lakh rupees, we don't bother about it. But putting a PIC line, we say it is expensive. It is not expensive. It's our mindset that needs to be changed, and we need to build our level of confidence so that we put in more PIC lines. And I'll request all the participants to involve in PIC workshops in the future. With this, I would like to thank all the participants and thank all the speakers and panelists. With this, we'll conclude the session. Thank you very much. I'll request the speaker to come forward for a group photo. Thank you very much. I'll also request Dr. Madindra to come forward as the program director of the workshop, who ignite.